a 59-year-old white male that was referred to our vascular surgery clinic for bilateral calf claudication, left side worse than the right. His symptoms got progressively worse to where he was having pain after walking 30 to 40 feet, and eventually did progress to rest pain. We had problems differentiating rest pain from his severe baseline diabetic neuropathy because he described a constant pins and needles sensation in both of his feet, even at rest. Past medical history, usual suspects: hypertension, hyperlipidemia, diabetes, AFib, coronary artery disease. He had 3 STEMIs in the last 15 years, and then peripheral artery disease. Surgical, he had 2 PCIs with a drug-eluting stent in the proximal LAD. He had a pelvic arteriogram at an outside hospital with left external iliac stenting. And he was a 2-pack per day smoker on Xarelto, insulin, beta blocker, amlodipine, aspirin, and a statin. For his exam, he had non-palpable femoral and popliteal pulses, and he had Doppler signal at the posterior tibial bilaterally, dependent rubor bilaterally, and he did have tissue loss. He had gangrenous changes on the left foot of the 3rd and 4th toes, as well as cellulitis to the midfoot. For his studies, he had a leukocytosis to 16,000 with an elevated CRP, and his non-invasive studies showed ABIs right around 0.45, and then toe pressure on the right of 52 and on the left of 40. And he had significant blunting of his pulse volume recordings at the level of the thigh, suggesting severe inflow disease. Given his history, we decided to get a preoperative cardiac evaluation. His NST showed an inferolateral wall perfusion defect concerning for ischemia with preserved EF. He did go for left heart cath that showed stable 2-vessel coronary artery disease with a patent stent. So I'm going to show these images in a second, but just to give you guys an idea of what to look for, he had severe multi-level disease bilaterally with right external iliac stenosis. His right common fem was out. His right profunda was patent, but just barely, and then his left external iliac stent was occluded with common femoral stenosis, SFA disease, and also an occluded left main profunda as well. So we'll go through these images. This is just one representative scan for him. It's going to scroll through kind of slowly, but once the findings come, they find pretty quickly. So as we go down, you'll start seeing some common iliac disease, and then we'll come up on his occluded stent on the left right there. You can see that the right external iliac is patent slightly, and we'll keep going down. You'll see that both profundas are out as well. There's some outflow. As we go more down, it's better on the right than on the left. And that should be basically it. Okay, great. So we know that concurrent inflow and outflow procedures, especially with an aortobifemoral bypass, are very rare. And we went through a lot of different options to address this tissue loss on the left side. We thought about a femoral endarterectomy, an iliac stent, and then distal bypass, so a one-sided procedure. We also thought about endo options or a different open revascularization with an Axbi-Fem. But given his anatomy and his tissue loss and his bilateral rest pain, there were no really good endo-staged or unilateral options. So like I mentioned, we did the cardiac workup and then proceeded with the aortobifemoral bypass with concurrent left femoral to posterior tibial bypass. So in the operating room, we did the AFB with the 16x8 Dacron graft. We did a left femoral to posterior tibial bypass with a non-reverse saphenous vein from the left side. He also had a right common femoral endarterectomy with a small amount of profundoplasty, and then we re-implanted the inferior mesenteric artery at the end of the case as well. Postoperatively, the patient did well. He had a palpable left posterior tibial pulse right out of the operating room. His toe pressures the next day were 67 and 86, so a significant improvement. Within 30 days, he did develop a seroma in the left leg vein harvest site that was evacuated without any issues. His tissue loss did heal, and his claudication and rest pain improved. So just briefly, a small discussion. 50% of patients that make it to the operating room for aortoiliac who makes the operating room for aortoiliac surgery for peripheral arterial disease have multi-level disease. And traditionally, this was described as to be treated with an inflow procedure only, but data and studies have shown that of the patients that have an inflow procedure, 25 to 33% will inevitably need a distal bypass as well. And initially, it was thought that these distal bypasses don't have a good patency rate if you do them concurrently, but new studies have shown that patency is as high as 90% at 2 years and 70 to 80% at 4 years. So these procedures do have utility in multi-level disease. So these are my references. Thanks for having me. I'll open it up to any questions.
Again, very interesting case. Really thought the use of imaging here to help, really, you made a decision that a patient needed to be revascularized. Being able to use then the CTA to really plan your procedure, I think, is really helpful. You probably prevented, having to at least do some kind of angiogram or do some kind of invasive procedure by being able to plan this. Would your plan have been different if the patient was, let's say, Rutherford class 3, a claudicant, as opposed to someone with an ulcer in a Rutherford class 5? Would that have changed what you did?
That's actually an excellent question, something that we discussed a lot. We had known this patient from earlier when he was only a claudicant without tissue loss, and the plan was an AFB, possibly, but it's not generally our practice to do an advanced open procedure for just claudication. We know that the risk of limb loss is a little bit lower with claudication, but once they progress to rest pain or tissue loss, the risk of amputation goes significantly higher, and that's why we made the decision to perform the concurrent operations.
Excellent case, again. Just curious about, did you guys think about any medical therapy changes after this? Because one, this is a gentleman who's had significant coronary disease. Now he's got multi-level peripheral artery disease. So his 5-year survival is not going to be as great as somebody without any of these. So any consideration for medical therapy changes? So
because I'm just a resident, I rotated off the service before he was able to follow up, but I do know that he was inserted into he was inserted into an exercise program as well as a smoking cessation clinic, because while he was compliant with medications, he would just not stop smoking. So those are the two things I know for sure that we did for risk factor modification.
Well, great case, very complex. They don't come much more challenging. I wonder if your approach would have been different had this guy been bypassed and not had autologous vein graft to use for that FemPop.
So that's a tough question. I don't know for sure, but I do know that he did have good vein on the right. So he had some good vein on the right side. We probably still would have proceeded and used a prosthetic graft for the bypass, but I'm not 100% sure.
Sure, great. Well, thank you very much. That was a great case.
Thank you so much.